So we've already spoken about deep venous thrombosis, and in this module we'll talk about another very important topic, that is varicose veins. MCQs are asked from varicose veins, and also sometimes this comes as a short note and a short case in your college exams. So varicose veins, before we talk about it, let's discuss the surgical anatomy of the venous system of the lower limb. Now we know that the venous system of the lower limb, you have a superficial venous system and you have a deep venous system. So this is the superficial venous system, and it is connected with the deep venous system via perforators. So this is the superficial, and the superficial system only carries 20% of blood, and the blood flows from below upwards. So it is unidirectional flow which is guarded by valves. In the deep system, 80% blood flows through the deep system, and the deep system is also guarded by valves, and this also ensures unidirectional flow of blood. Connecting the superficial and the deep system are perforators, and these perforators also ensure unidirectional flow of blood from the superficial to the deep system. Now, if you look at the anatomy, the deep veins, there are three pairs of deep veins which are there. Right? You have peroneal veins, you have anterior tibial veins, and you have posterior tibial veins. So there are three pairs, which means there are 6 veins. And when these 6 veins join, they form the popliteal vein. They form the popliteal vein, which further goes up into the superficial femoral vein and then into the common femoral vein. So these are the deep veins of the lower limb. The superficial veins, there are 2 major systems in the superficial veins. You have the great saphenous system and you have the short saphenous system. Now the great saphenous system, if you look at the great saphenous system, the great saphenous system vein, it starts from the medial end of the dorsal venous arch, medial end of dorsal venous arch, and then it lies just anterior to the medial malleolus, right? This is a very important location for the great saphenous vein, because if you remember your trauma module, I told you this is the location where a venous cut down is done. Okay, and let me show you a picture, a clinical picture. So you can see this is the medial malleolus and this is anterior to it. This is your great saphenous vein. This is the great saphenous vein, and in people where it is so prominent, you can easily dissect it and you can do a venous cut down at this location. Then it lies on the medial aspect of the knee. Then it lies along the medial aspect of knee. And finally, it drains into the saphenofemoral junction. The saphenofemoral junction is situated 4 centimeters below and lateral to the pubic tubercle. And this has a constant location. So that is the importance, that this has a constant location, so it's easier for us to identify it when we are doing surgery. 4 centimeters below and lateral to the pubic tubercle. So let's just trace the great saphenous vein. You can see here, this is the great saphenous vein which is going up. It lies along the medial aspect of the knee, and finally it drains into the saphenofemoral junction. I also want you to know about the anterior or the accessory saphenous vein. This lies along the lateral aspect of the knee. And what is the importance of this anterior saphenous vein? Sometimes, rarely, you will find patients with isolated varicosities on the lateral aspect of the knee. So if there are isolated varicosities in the lateral aspect of the knee, you should think about the anterior saphenous vein being involved in those patients. So this was the great saphenous system. One more thing which I want you to know, which is very important for the exam, is that the great saphenous vein below the knee is closely associated. Below the knee is associated with the saphenous nerve. And what is the importance of this? The importance is that if you do stripping, which we'll talk about later, if you do stripping for the great saphenous vein, then you can injure the saphenous nerve. One more thing which you should know, and this was asked in the INI-CET exam as well, that for coronary artery bypass grafting, we use the saphenous vein graft. And when we are removing that saphenous vein graft, there can be injury to the saphenous nerve as well during that procedure. So that is another point which you should remember. The short saphenous system, the short saphenous vein arises from the lateral end of the dorsal venous arch, lateral end of dorsal arch, and this travels posteriorly. It travels posteriorly to drain at the saphenopopliteal junction. SPJ is the saphenopopliteal junction, and the saphenopopliteal junction has a variable location. So that is what I want you to know. This is very important. It has a variable location. Okay. So what is the importance of it having a variable location? One, we should always get it marked. In any patient where we are doing surgery, we should get it preoperatively marked. Otherwise, I have seen cases where you're just blindly searching and you don't find the saphenopopliteal junction. And because it has a variable location, there is also a higher recurrence following surgery in the short saphenous system. There is a higher recurrence in the short saphenous system following surgery. Another point which you should know, that the short saphenous vein is closely associated with the sural nerve, all along its course. That is why we don't strip the short saphenous vein, because if you strip the short saphenous vein, then you will cause injury to the sural nerve. So let's just trace the short saphenous vein. You can see this is the short saphenous vein which drains in the saphenopopliteal junction. Now, another very important term which is mentioned in the latest Bailey and Sebastian is that the cranial extension of the short saphenous vein is known as the vein of Giacomini, and this vein of Giacomini ultimately drains into the great saphenous vein. This is going to drain into the great saphenous vein. So this term also you should know for the exam. So this was regarding the anatomy of the venous system of the lower limb. I told you perforators also connect the superficial system with the deep system, and there are at least 100 to 150 perforators. So I remember 5 years or 6 years back, there was a question in the DNB exam, how many perforators are there? And majority of the students marked 8 or 10 because those were the named perforators. But in total, there are 100 to 150 perforators. So please don't get confused between the two. Now, there are certain named perforators as well. In the thigh, you have the Hunterian perforator. So the thigh perforator is the Hunterian perforator. Above knee perforator is known as the Dodd perforator. The below knee perforator is known as the Boyd perforator. There are 3 Cockett perforators. So there are 3 Cockett perforators. These Cockett perforators are situated 5, 10 and 15 centimeters. 5, 10 and 15 centimeters above the medial malleolus. 5, 10 and 15 centimeters above the medial malleolus. And at the level of the heel, you have the May or the Custer perforator. So these are the named perforators, and you should know the great saphenous vein and the SFJ junction, the saphenofemoral junction, is the largest perforator in the body. So this was regarding the perforators as well. Now, what is the pathophysiology behind the development of varicose veins? So, varicose veins, first you should know the definition. These are dilated tortuous veins with defective valves. Dilated tortuous veins with defective valves are varicose veins. So we'll talk about the causes of varicose veins, but first let's understand pathophysiology behind this. So normally we know that blood from the lower limbs is returned to the heart in an anti-gravity fashion. It goes from below upwards. So what are the factors which help in this anti-gravity movement of blood? So one factor is that whenever we take a deep breath, when we do inspiration, there is negative pressure created in the thorax, and this negative pressure creates a gradient by which the venous blood moves upwards. The main reason why venous blood moves upwards is the compression of the surrounding muscles. So the surrounding muscles, when you're doing activity, they contract, and they are the ones which push the blood upwards. Okay. And normally what happens, that supposing we start exercising, then the superficial venous system, the pressure in the superficial venous system reduces, and all the blood goes to the deep venous system, 80% of it. But in certain patients where the valves are defective, there can be reflux of blood, and that gives rise to increased pressure in the superficial venous system. That gives rise to increased pressure in the superficial venous system, and that is known as the ambulatory venous hypertension theory, which is one of the most accepted theories behind the development of varicose veins. That in normal patients the pressure reduces, but in patients where there are defective valves, the pressure in the superficial system will increase. Now, varicose veins can either be primary varicose veins or they can be secondary varicose veins. Primary varicose veins are seen in patients with defective valves, or absent valves, congenital absence of valves. That is where you see primary varicose veins. Secondary varicose veins can be secondary to DVT. And if you remember the module on DVT, I told you about the post-thrombotic limb, a post-thrombotic limb, which can give rise to varicose veins as well. And we know the reason why, because if the deep veins are thrombosed, 80% of the blood was supposed to flow through them. Now, all the blood will flow through the superficial system, and that will give rise to varicosities. So it can be secondary to DVT, it can be secondary to abdominal or pelvic masses. So abdominal or a pelvic tumor or a sarcoma or advanced cancer can press on the venous system and can give rise to varicosities. Okay. So in these patients, clinically, I want you to know one thing, because this your examiner will ask you if you're given a short case, that if you have varicose veins secondary to an abdominal or a pelvic tumor, the varicosities will extend above the inguinal ligament as well. Otherwise, normally, they will not extend above the inguinal ligament. So this is a point which you should remember for your exam. Now, what are the risk factors which can predispose to varicose veins? So, family history is very important. Then you can have occupational hazards, right? It can be an occupational risk. So, hawkers, security guards who have to stand for a long duration, for that matter, even teachers who have to stand for long durations can get predisposed to varicose veins. In fact, before the era of iPads and tech notes and online classes, we used to be writing on the boards, and I used to be probably standing for 8-9 hours a day. And by the end of the day, the legs used to really hurt, and there used to be dilated veins as well. And a lot of times I thought that I'm going to develop varicose veins. In fact, a lot of times I used to take classes and I used to wear compression garments as well, because that used to give relief. So occupational risk, family history can be there. It has also been seen that secondary varicose veins are more common in females as compared to males, more common in obese patients, and it is common during pregnancy also. So these are the risk factors for varicose veins which you should know about, and primary and secondary varicose veins. Now, what are the clinical features with which patients are going to come to us? So the clinical features, the most common clinical feature is that the patient is going to say that they have dilated veins in the legs. They can also have dull aching pain, or there can be pigmentation. This pigmentation is because of hemosiderin deposition. This has also been asked in the exam. It is because of hemosiderin deposition. Now, these dilated veins, depending on the size, there are different names for these veins, and they have been asked quite frequently in the exam. Now, if you have a dilated vein which is more than 3 millimeters in diameter, so if the diameter of the vein is more than 3 millimeters, then we call it a varicose vein. Then we call it a varicose vein. If the diameter is 1 to 3 millimeter, then these are known as reticular veins. And if the diameter is less than 1 millimeter, then we call them dermal flares or thread veins. So then these are known as dermal flares or thread veins. So these are the three types of veins which you can see in a patient with varicose veins. And you should know that varicose veins and reticular veins are a functional plus a cosmetic problem. So they are a functional problem as well as a cosmetic problem. Whereas dermal flares and thread veins are only a cosmetic blemish, right? They are a cosmetic problem predominantly. So let's look at the images of these veins. So this you can see are varicose veins. You can see on both the sides extensive varicosities are there, and these are more than 3 millimeters. You can even see the pigmentation here, which is because of hemosiderin. This pigmentation is because of hemosiderin deposition. You can see another patient where you can see the varicosities very well outlined here. And these are thread veins, right? These are thread veins. These are more a cosmetic problem. So we won't call them varicose veins. According to the size, we'll call them thread veins. So these are thread veins which are less than 1 millimeter in size. Now, there are certain other presentations also which have been mentioned in the latest Bailey and Sebastian. And these are very, very important because in the last 3-4 years, lots of questions have been asked regarding them. The first one is a corona phlebectasia. Corona phlebectasia is also known as a malleolar flare. It is also known as malleolar flare, and it is a fan-shaped arrangement of telangiectasic vessels, right? So telangiectasic vessels are also less than 1 millimeter, and this is thought to be an early sign of advanced venous disease, right? It is thought to be an early sign of advanced venous disease, and you can see here, this is the malleolar flare which you can see, right? Even in the previous image, you can see the malleolar flare. So this is corona phlebectasia. Another term is atrophy blanche. Atrophy blanche is a pale white area, surrounded by dermal flares or thread veins. That is known as atrophy blanche. So you can see this whitish hypopigmented area, and you can see the varicosities around it, right? You can see this and you can see the varicosities around it. So this is known as atrophy blanche. This is also thought to be an early sign of advanced venous disease. Okay, so this also you should know about. Lipodermatosclerosis is the one which has been asked multiple times. So again, an advanced sign of venous disease. Lipodermatosclerosis is when the fat obliterates. When the fat in that area obliterates, you have a woody feel. There is a woody feel to the leg, and there is contracture of the tendoachilles, and there is contracture of tendoachilles in these patients, and the appearance which you're going to get is an inverted champagne bottle appearance. So it looks like the champagne bottle has been turned upside down. This is an inverted champagne bottle appearance which you get in lipodermatosclerosis, and this is also an advanced sign of venous disease. Of course, in patients with varicose veins, there can be venous ulceration as well. And I've discussed venous ulceration in detail towards the end of this module. That is a separate short note and a case in your exam, which can be asked. So we'll discuss that at length towards the end of this module. So these are the various presentations with which the patient can come to the clinic. Now, when the patient comes, we have to classify these patients according to the CEAP classification. And this is probably the most hot topic in the last 4 years. There isn't a single exam in which they haven't asked questions from the CEAP classification. So the C part of the CEAP classification is the clinical classification, and you need to memorize this. Okay, you need to memorize this. This is the latest modification which occurred in 2021, and you should know the details about this. C0 is no visible or palpable signs of venous disease. C1 is telangiectasic or reticular veins. We know telangiectasic veins are less than 1 millimeter. Reticular veins are 1 to 3 millimeters. C2 are varicose veins. C2R is a new category which has been added. This is recurrent varicose veins. C3 is edema. C3 is edema. C4 is very important. A lot of questions have been asked from C4. C4A is pigmentation or eczema. I told you pigmentation is because of hemosiderin deposition. You can have C4B, which is lipodermatosclerosis or atrophy blanche. C4C is corona phlegmectasia. So these you should remember. C5 is a healed ulcer and C6 is a active venous ulcer. C6R is a recurrent active venous ulcer. This is also a new category which has now been added to this classification. So you need to remember the classification for your exam. You can be shown an image like this, right, where you can see there is an active ulcer. So this is going to become C6, right? So you can be shown images like this. You can be shown lipodermatosclerosis, and you can be asked which grade is it according to CEAP. So this will be C4B. So you need to remember the classification. Now the E is the etiological classification, whether it is congenital varicose veins, primary varicose veins, secondary, that is post-thrombotic, secondary to DVT, and no venous etiology is EN. A is for anatomical, whether superficial, perforator, deep veins are involved or no venous location is identified. And pathophysiological classification is whether it is secondary to reflux, obstruction, both reflux and obstruction, or there is no pathology identified. So this is the CEAP classification which you should know about. Now, when the patient comes to the clinic, we will carry out certain clinical tests. And these clinical tests are particularly important when you're given a case of varicose veins. Okay, so let me just briefly describe these signs to you, and then I will show you a couple of videos where I've demonstrated these signs as well on a patient. So the clinical signs, the most commonly done test is the Trendelenburg test. Now the Trendelenburg test has two parts to it. So the first way to do Trendelenburg test is, you will see in the video, we first raise the leg and we empty the veins. We milk the veins, right? We milk the veins. And then we tie a tourniquet. We tie a tourniquet just below the saphenofemoral junction. So after emptying the leg, we tie a tourniquet just below the saphenofemoral junction. Then we make the patient stand up. Okay, we make the patient stand up. And then we are going to open the tourniquet. Open the tourniquet. Now, when we open the tourniquet, in normal people like us, there is gradual filling. But if there is rapid filling, in these patients, then what does it denote? It denotes that the saphenofemoral junction is incompetent. It denotes that the saphenofemoral junction is incompetent. The other part to the Trendelenburg test is, we again milk the veins. We again tie a tourniquet. Just below the saphenofemoral junction. We make the patient stand up, right? We don't open the tourniquet. And if you see filling from below, right? So if we see filling from below, then it denotes that perforators are incompetent. Then this denotes that perforators are incompetent. Okay. So these are the two parts to the Trendelenburg test. I will show you a video to demonstrate these signs as well. You can have certain non-specific signs like Morris's cuff impulse, where you keep your fingers on the saphenofemoral junction. You ask the patient to cuff, and if you feel a thrill there, then that means there is incompetence of the saphenofemoral junction. Schwartz test is when you tap over the vein, and if you feel a thrill at the saphenofemoral junction, then it denotes that there is incompetence. The Figan's method and the multiple tourniquet tests are done to identify the location of, this is done to identify location of incompetent perforators. Location of incompetent perforators we will get to know by the Figan's method and the multiple tourniquet test. In the Figan's method, what is done? So Figan's method, what is done? You first mark the outline of the vein using a marker. So when the patient is standing, you will mark the outline of the vein using a marker. Okay? Then you make the patient lie down and you empty or you milk the veins. And you will see in the video, I'll show you. Then you feel along the marked path, the one which you've marked. And wherever we feel a blowout, wherever we feel a blowout or a depression, that is the site of incompetent perforators. So wherever you feel like a depression there or a blowout there, that is the site of incompetent perforators. In multiple tourniquet tests, remember I told you about the named perforators. So you tie multiple tourniquets, one at the thigh, one above knee, one below knee, and then for the cocket perforators. And in between the two tourniquets, whenever you get dilated veins, that is the location of incompetent perforators. So these two tests basically help you to identify the location of incompetent perforators. The modified Perthes test is done to rule out deep venous thrombosis, whether deep veins are normal or not. So in modified Perthes test, we tie a tourniquet without emptying the veins, below the saphenofemoral junction. Then we make the patient stand up and we make the patient walk. So in a normal person, what is going to happen? In a normal person, this is the superficial system, this is the deep system, okay? Now I have occluded the superficial system by tying a tourniquet. In a normal person, all the blood will now flow through the deep system, and when you make the patient walk, the veins will collapse, the varicose veins will collapse, and the pain will reduce. The patient will not have pain. But if the deep veins are thrombosed, if supposing the deep vein is thrombosed, I've already tied a tourniquet in the superficial veins and the deep vein is thrombosed. So if DVT is there, the blood will not be able to go up. So in DVT, pain will increase and the veins will become more distended. So this is the modified Perthes test which is done. Now, why is it important to rule out DVT before doing varicose veins management? It's common sense. If the deep vein is thrombosed and supposing I remove the superficial vein, I remove the great saphenous vein, then there'll be no venous drainage left for the limb. And the patient is going to develop large amounts of edema, and in some patients that can even give rise to later on gangrenous changes as well. So we don't want that. You don't want to make that mistake. So before doing varicose vein surgery, always rule out deep venous thrombosis. So with this information in mind, let's now see the clinical videos of where I've demonstrated these signs on a patient. So this was a patient of varicose veins where he was about to undergo surgery and the preoperative marking had been done. And now you can see in most of the tests, we need to first milk out the veins. We need to elevate the leg. You can see I'm elevating the leg and I'm milking out the veins. I'm emptying the veins, and then I will identify the saphenofemoral junction. I'll do the surface marking and then we'll tie the tourniquet below the saphenofemoral junction to carry out the Trendelenburg test. So you can see here that I've milked out the veins. The vein was already marked and now I'm feeling along the vein. This is known as the Figan's method, and you can see here I can feel a blowout here. I can feel a blowout here, and this is on the same portion where the radiologist has marked it on Doppler as well. So that is the site of incompetent perforators, right? So we mark the vein, then we feel along the vein, and wherever we feel a blowout, that is the incompetent perforator. So you can see the pubic tubercle. that is the pubic tubercle, and the saphenofemoral junction is going to lie 4 centimeters below and lateral to the pubic tubercle. So you can see that from the pubic tubercle, I'll measure now. That is the pubic tubercle which I'm feeling. And from there, I will measure using a scale. And in your exam, mind you, if you're shown a case of varicose veins, please carry a scale with you. Otherwise, just don't make approximate guesses. Otherwise, examiners can get really annoyed. So 4 centimeters below and lateral, you can see that is the saphenofemoral junction, and that also we will mark. Now to do the Trendelenburg test, we are going to tie a tourniquet below the saphenofemoral junction once we've emptied the veins, which I showed you how we do. So now you can see the tourniquet has been tied below the saphenofemoral junction, and now we make the patient stand up, and if there is gradual filling from below, that denotes incompetent perforators. And in Trendelenburg test, if I open up the tourniquet and if I see rapid filling from above, then that denotes that there is an incompetent saphenofemoral junction, right? So these are the two parts of the Trendelenburg test, and in these videos I've demonstrated the surface marking, Trendelenburg test, and how we do the Figan's method. We can also do the multiple tourniquet test to identify the site of perforators. So one thing which I want you to remember, that all clinical tests have a low sensitivity. They have a very low sensitivity, which is why when you get a patient with varicose veins, we have to carry out certain investigations as well. And the investigation of choice is a Doppler or a duplex scan. A duplex is nothing but a Doppler with B mode ultrasound. That is a duplex scan. Now, a Doppler tells us about the flow of blood, the direction of flow, and whether reflux is present or not. Now, the direction of flow away from the heart, it is red in color. And if it is towards the heart, it will be blue in color. Towards the heart, it will appear blue on the duplex scan. And we have to demonstrate reflux as well. Reflux is defined as retrograde flow lasting for 0.5 seconds or more. That is the definition of reflux according to the latest Sebastian. And how can we initiate the reflux? We can squeeze the calf to see if reflux is occurring or not, right? So this you should know, Doppler or duplex is the investigation of choice in patients with varicose veins. Another point which I want you to know, when we do this duplex scan, we get a Mickey Mouse sign. Where else did we talk about Mickey Mouse sign? Correct. The portal triad, right? In liver, I told you, there also we can get a Mickey Mouse sign. Here also we get a Mickey Mouse sign, where we will get the great saphenous vein, the femoral vein, and the common femoral artery. The common femoral artery will be visualized, and this gives us the Mickey Mouse sign in patients with varicose veins, or even normally in a normal person also you will see these three things: the great saphenous vein, the femoral vein, and the common femoral artery. So this is the investigation which needs to be done in all patients with varicose veins. Now, how do we manage patients with varicose veins? So management of varicose veins patient, you have to carry out adjunctive treatment, adjunctive management, and the definitive management. Now, the definitive management are, of course, surgical options, which I'll discuss. But first, let me talk about the adjunctive management, which needs to be done in addition to the surgical management. And the adjunctive management is mainly in the form of compression garments, is in the form of compression stockings, and dressings if there is an ulcer. And we have to carry out dressings as well. Now, the adjuncts to the surgery are compression garments, and you should know that Class 1 compression garments are 14 to 17 millimeters of mercury, Class 2 are 18 to 24, Class 3 are 28 to 35, and Class 4 are more than 35 millimeters of mercury. In patients with varicose veins, we usually use Class 3 compression garments, but there is low compliance. And that is why we have to carry out the definitive treatment, that is surgery. 2 points which I want you to know here. If you remember the module on lymphedema, I told you for lymphedema, the pressure of the garments required is more as compared to varicose veins. So higher pressure is used when we are managing lymphedema vis-a-vis varicose veins. That's number one. And number two, some patients might have arterial plus venous disease. So they can have arterial compromise as well. So if there is arterial plus venous disease, we'll have to be careful about using compression garments, because in patients with low ankle brachial pressure index, this I've covered in the arterial module, ABPI's ankle brachial pressure index. This is very important. It has been covered in detail in the arterial module. We will have to avoid compression garments. Because if you use a tight compression garment, then you're going to occlude the arterial supply as well in these patients. Dressings are used when there is an ulcer, and I will talk about that in ulcers, that we don't use prophylactic antibiotics in venous ulcers because that can give rise to resistance as well. Now, the definitive management is, of course, surgery. And to understand the surgery, I would like to divide it under three headings. So let's talk about surgery for the great saphenous vein and saphenofemoral junction incompetence. We'll talk about short saphenous vein and SPJ incompetence. And we'll talk about perforator incompetence. So these are the three headings under which we need to talk about the various surgical methods which are there. Now, great saphenous vein and saphenofemoral junction incompetence, the traditional surgery which was done in this sitting was the Trendelenburg's procedure. Now, what is the Trendelenburg's procedure? So, Trendelenburg's procedure is just flush ligation of the saphenofemoral junction. Is Trendelenburg's procedure. So you can see here, this is the saphenofemoral junction. This you can see is the femoral vein. This is the femoral vein. This is the saphenous vein. And you will tie it as close to the femoral vein as possible. So flush ligation. So flush ligation means as close to the junction as possible, right? So if this is the thing, we are going to tie it here. And why not certain distance away? So if you leave a stump, that stump can swell up and that can form a saphena varix, right? That can form a saphena varix, which is why we do flush ligation and we don't leave a stump behind. Now, one thing which I want you to remember, that when we are doing Trendelenburg procedure, we have to ligate tributaries when we are doing Trendelenburgs, and there are 6 tributaries which need to be ligated. Otherwise, there is a high recurrence rate. And what are these tributaries? Medially, you have the superficial external pudendal and the deep external pudendal. Distally, you have the accessory anterior saphenous vein and the posterior medial thigh vein. Laterally, you have the superficial epigastric and the superficial circumflex iliac veins. If these tributaries are not ligated, then there is a high recurrence rate in Trendelenburg procedure. Patients with Trendelenburg procedure. So this you should know about. Another thing which I want you to know, that Trendelenburg's procedure is just flush ligation of the saphenofemoral junction, right? Stripping is additional. Stripping is an additional procedure. It is not a part of Trendelenburg procedure. So please remember that it is not a part of Trendelenburg procedure. And you can see how we strip the vein. So we put a stripper and we get it out at close to the knee, and then we pull out the vein. We strip out the vein. We completely remove it. That is known as stripping of the great saphenous vein. And you should know that stripping of the great saphenous vein is done till the knee joint. Not below knee. Why not below knee? This I told you when I was covering the surgical anatomy. So if it is done below the knee, then which nerve can be injured? Correct. The saphenous nerve can be injured. That is why we don't strip the great saphenous vein below the knee joint. So this was the traditional surgery which was being done for great saphenous vein and saphenofemoral junction incompetence. What we are doing now, the latest procedures or the surgery of choice is EVLT or RFA. EVLT stands for endovenous laser therapy. And RFA is radio frequency ablation. So these are the two procedures which are being done. Now Bailey and Sebastian both say that they both are the treatments of choice. You can't choose between one because each has its pros and cons, which I'll talk about. So EVLT, we use a 1470 nanometer laser, and this produces 60 joules per centimeter of heat. And because of this heat, the veins become collapsed. So you insert a laser catheter into the vein and you keep on firing and you keep on withdrawing it. So it will just keep on collapsing the vein. Now there are two types of EVLT probes which are there. One is forward firing and one is lateral firing. Lateral firing is better because there is more uniform distribution and there is less risk of perforation. In these patients. Okay, so that is why lateral firing is preferred over forward firing probes. So this was a picture which I had clicked when I was doing my fellowship in Bangalore, and this is what the laser is doing. Laser is producing electricity and is producing heat, because of which the vein is getting collapsed. So you can see here, this is the EVLT fiber which is being put in, and you produce heat and you keep on withdrawing it. You continuously keep on withdrawing, and as you are withdrawing, one person is putting pressure. So the vein wall is going to collapse, keeps on collapsing. So this is EVLT. RFA is temperature of 120 degrees is reached and it is a 20-second cycle. Now RFA, the advantage is that it has a shorter learning curve. As compared to EVLT, and continuous pullback is not there. Continuous pullback is not required. Okay. But EVLT has one advantage, that EVLT can be used for any vein. So it is more flexible, more versatile as compared to radio frequency ablation. So these were some points which I wanted you to know regarding EVLT and RFA. And this is the procedure of choice these days when we are doing surgery for the great saphenous vein and the saphenofemoral junction. So you should remember that these endovenous procedures are being preferred. Why are endovenous procedures like EVLT and RFA preferred? Endovenous procedures are better because there is less recurrence. There's faster recovery. There's faster recovery after surgery. That is why these endovenous procedures have become the procedures of choice these days for varicose veins. Now, short saphenous vein and SPJ incompetence. The traditional procedure is flush ligation of SPJ. Traditional is flush ligation of saphenopopliteal junction. There is no stripping. No stripping is done because you can injure the sural nerve. This we've discussed. You can injure the sural nerve. And one thing which I told you previously, that always pre-operatively mark SPJ. Right, because SPJ has a variable location. So if you don't do pre-operative Doppler marking of the SPJ, you will just be searching in the blind and you will not be able to find SPJ in a lot of cases. So that is why pre-operative marking, and this is the role of the first year postgraduate. And I have seen first year postgraduates getting a real scolding that if the marking of the varicose vein patient is not done pre-operatively. So this should be done beforehand. The latest procedure is again EVLT or RFA. That is the procedure of choice for saphnopopliteal junction as well. Now moving on to perforator incompetence. So if there's perforator incompetence, the traditional surgery was Dodd and Cockett's procedure. The traditional surgery was Dodd and Cockett's procedure. This was known as multiple subfacial ligation of perforators. Subfacial ligation of perforators. So these perforating veins are partly above the fascia and partly below the fascia. So in multiple subfacial ligation, what is done is that we will make an incision on the skin. Wherever there is an incompetent perforator, I will make an incision in the skin. I will dissect this perforator and then I will tie it above the fascia and I will tie it below the fascia. So in multiple subfacial ligation, multiple skin incisions were required. That is why it was cosmetically inferior. So this is cosmetically inferior because multiple skin incisions were required. So after Dodd and Cockett came a procedure which was known as SEPS. SEPS has also been asked in the exam multiple times. SEPS is subfacial endoscopic perforator surgery. Is subfacial endoscopic perforator surgery is SEPS. Okay. So in SEPS, what is done is that through one of the incisions, we are going to put in a camera. Right, like we were doing in laparoscopy, we put in a camera, and with this camera now I can see all the incompetent perforators, right? So this camera is below the deep fascia and I can see all the incompetent perforators and I can just keep on ligating or clipping them. That is known as SEPS. So less number of incisions to do the same procedure. But again, these days the latest procedure for perforators is also EVLT or RFA. So this was the surgical management for varicose veins. I've told you about great saphenous vein, short saphenous vein and perforator incompetence and how do we deal with them. Now there are some newer modalities which are also being used to manage varicose veins. The newer modalities which are being used are endovenous glue therapy and the glue which is being used is the cyanoacrylate glue. So basically what we are doing is we are emptying the vein and then we are putting in a lot of cyanoacrylate or Fevikwik inside the vein. And you've used Fevikwik, once you put it, it just gets dried up very quickly and stuck very quickly. So that's what is going to happen. It will just collapse the two vein walls when you put in this glue inside. So another procedure is Trivex. Trivex is transilluminated powered phlebectomy. Transilluminated powered phlebectomy is Trivex. So in this we put a subcutaneous illuminator. So we put a light source in the subcutaneous plane, and when we do that, you can see that the vein becomes visible, right? You can see that the vein becomes visible, and when the vein becomes visible, we can use a phlebectomy instrument. To draw out this vein and ligate it. So that is Trivex. Another newer modality is foam sclerotherapy. Which is being used. And foam sclerotherapy, the sclerosing agents which are used. So the sclerosing agents I've covered at a lot of places. Sclerosing agents, I've told you, most common is sodium tetradecyl sulfate. This I've covered in upper GI hemorrhage and in hemorrhoids also. Polydocanol is being used. Sodium morowate is being used. So these are some of the sclerosing agents which are being used for varicose veins as well. And sclerosing agents, basically they induce inflammation. And when they induce inflammation, the two vein walls will become collapsed or they'll fibrose. And that is how they work. Now, one problem with normal sclerotherapy is that when sclerosin comes in contact with blood, it will not induce fibrosis in the wall. That is why foam is being used. Foam leads to better distribution. Of sclerosant, and better action. Now, how is this foam created? This foam is created using the Tessari's technique. This has been given in Bailey and Sibiston, and Tessari's technique is when we use one part of sclerosant and 3 parts of air, or 1 part of sclerosant and 4 parts of air. Both the values are given. 1:3 or 1:4 is used to create foam which will have better action. Now, foam sclerotherapy can only be done for veins which are less than 3 millimeters in diameter. So they can only be done for reticular veins and thread veins. You cannot do foam sclerotherapy for varicose veins. And foam sclerotherapy is associated with a high recurrence rate as well. There is high recurrence rate and high complication rate in foam sclerotherapy. Now, we need to talk about varicose vein surgery. What are the complications? So, the complications of varicose vein surgery: wound infection is the most common complication. This has been asked in the exam. Wound infection is the most common complication following varicose vein surgery. Bruising can occur, and bruising is more after endovenous procedures. There can be recurrence, and I told you why short saphenous vein recurrence is higher, because it has a variable location. The saphenopopliteal junction has a variable location, so the recurrence is higher in the short saphenous vein as compared to the great saphenous system. There can be bleeding. There can be injury to the nerves. I've already told you about saphenous and sural nerve. They've been asked in the exam as well. Again, if the surgeon is too adventurous, he can injure the femoral vessels as well. So these are the complications of varicose vein surgery, where I want you to remember about wound infection, and I want you to remember injury to the nerves. What are the complications of varicose veins itself? So the complications of varicose veins, these veins can start to bleed. And we saw a couple of patients during our post-graduation where the patient came with massive bleeding, and all you need to do is you need to elevate the limb. You just need to elevate the limb, and when you elevate the limb, the bleeding will automatically stop. Avoid tying tourniquets because that will lead to increased bleeding. So just elevation is good enough. Veins can become calcified. They can feel cord-like. There can be superficial thrombophlebitis. Pigmentation, I've already told you, because of hemosiderin deposition. Lipodermatosclerosis, we've already discussed. You get an inverted champagne bottle appearance. And finally, you can get ulceration as well. So let's talk about venous ulcers, which is a very important complication of varicose veins in terms of exams and even in terms of a short case in your university exams. So these venous ulcers or varicose ulcers, as you can see, these venous or varicose ulcers, the theory behind it is the ambulatory venous hypertension theory, which I've already covered. I've already explained ambulatory venous hypertension theory. And these ulcers are commonly found along the medial malleolus, and this is also known as the gaiter area of the leg. This area is also known as the gaiter area of the leg. So this is the most common site where venous ulcers are found, medial malleolus or the gaiter area. But a trick question for you can be that sometimes you can have an ulcer on the lateral malleolus as well. Lateral malleolus, if you get an ulcer along the lateral malleolus, then it is associated with the short saphenous vein. But majority of the ulcers are along the medial malleolus in association with the great saphenous vein. Now the features of these ulcers, I've covered this in the common ulcer module as well, but I'm going to repeat it here. The features are, it is a shallow ulcer. It is a shallow ulcer. It has sloping edges. Shallow ulcer, sloping edges. There is pale granulation tissue on the floor. There is pale granulation tissue on the floor, and it has pigmented margins. And it has pigmented margins, which I've told you are because of hemosiderin. Now, in these patients, whenever you're given a case of an ulcer, and I've covered this in the case discussion of an ulcer as well, that whenever you're given a case of an ulcer, always describe the limb and then the ulcer, right? Don't only focus on the ulcer, you have to focus on the limb as well. And always examine pulsations. Always examine pulsations in patients with venous ulcers as well, because sometimes there can be a mixed pathology where the patient can have arterial and concomitant arterial and venous disease. So you need to examine the pulsations in these patients as well. Now, another patient of varicose ulcer, you can see another varicose ulcer. You can have recurrent varicose ulcers as well. Now, the management of venous ulcers or varicose ulcers is by the Bisgard's regime. And what does the Bisgard regime say? The Bisgard regime says that you have to educate the patient, tell the patient about his problem. Elevation of the limb has to be done. Elastic compression stockings. And elastic compression stockings, we classically use the 4-layer bandaging technique for varicose ulcers or venous ulcers, where the first layer is wool, then you have a cotton crepe, then elastic bandage, then cohesive bandage, and you want to get a pressure of 35 to 40 millimeters of mercury. If arterial disease is also present, and the ABPI, ankle brachial pressure index, is between 0.5 to 0.8, then we only give a pressure of 30 millimeters of mercury. Then only 30 millimeters of mercury pressure is to be exerted. So that is why we have to rule out arterial disease as well. Dressings have to be done, and there is level 1 evidence. That surgery reduces the recurrence. Surgery reduces the recurrence of these venous ulcers. So we have to carry out surgery for varicose veins to reduce the recurrence of venous ulcers. You should know pentoxifylline is the only drug which has been approved. It increases the microvascular perfusion, and this is the only drug which has been approved to be used in patients with venous ulcers. So this is how we manage venous ulcers. One very important thing which you should know is a Marjolin's ulcer. A Marjolin's ulcer is in long-standing venous ulcers, or burn scars. These patients can develop a squamous cell carcinoma. Most commonly it is squamous cell carcinoma. Rarely it is a basal cell carcinoma as well, but mostly squamous cell carcinoma. So you will have a patient with raised everted edges, cauliflower-like edges. And when you do a biopsy, you will see that a long-standing venous ulcer or burn scar has converted into a Marjolin's ulcer. It becomes malignant, so there'll be rapid increase in size and the edges would become everted and cauliflower-like. The management of Marjolin's ulcer is surgical excision, and radiotherapy is avoided in these patients because it has been seen that if you give radiotherapy in patients with Marjolin's ulcer, they become more aggressive or they come back with a vengeance. So which is why radiotherapy is avoided and surgery is the mainstay of treatment for patients with Marjolin's ulcers. The image of Marjolin's ulcers has been asked in every possible exam, and they've also asked that it is commonly a squamous cell carcinoma. So this takes care of varicose veins. We've discussed right from the anatomy till the management and the complications as well. Before we end this module, there are 2 short topics. Only one has been asked as an MCQ, and that too, it was asked 4 years back. So you should know about Klippel-Trenaunay syndrome and Park-Weber syndrome. Klippel-Trenaunay syndrome is a mesodermal abnormality. It is a non-familial syndrome. And in this syndrome, what happens, there are vestigial veins, right? There are vestigial veins, there are varicose veins, and very importantly, there are absent deep veins. Also, these patients can have cutaneous nevi and soft and bony hypertrophy. Now, the problem is that these patients have varicose veins, but they have absent deep veins, right? So these varicose veins are the only source of drainage of venous blood. That is why varicose veins in Klippel-Trenaunay syndrome are managed conservatively, because the deep veins are not there. And that is why varicose veins are managed conservatively. This question has been asked. So in Klippel-Trenaunay syndrome, varicose veins are managed conservatively because the deep veins are absent. Okay, so this you should know. This syndrome should not be confused with Park-Weber syndrome. In Park-Weber syndrome, you can get multiple arteriovenous fistulae, and because of these arteriovenous fistulae, there can be a high output cardiac failure and there can be limb hypertrophy as well. So this was regarding the module on varicose veins. For final year students, short note on venous ulcer is very important. Short case on venous ulcer or varicose veins is very important. That is why I've demonstrated those signs to you. See those videos. You will get tips on how to carry out clinical examination, and also watch the module on common ulcers where I have described the case of an ulcer for you as well, and I've told you key pointers to keep in mind when you describe an ulcer. Varicose vein sometimes comes as a long question, rare, but usually it is venous ulcer or the complications of varicose veins which are asked in the exam. Now, before we end this module, let's quickly do some MCQs. The Mickey Mouse sign on B mode ultrasound in patients with varicose veins, which one of the following vessels is not included? Common femoral artery is included, great saphenous vein is included, common femoral vein is included, profunda femoris is not included. Which of the following signs is associated has been displayed on the image? So this is a giveaway. You can see these whitish patches. So this is atrophy blanche, where you have a depigmented area surrounded by thread veins or dermal flares. What pressure is to be exerted by class 3 pressure stockings? This we've already discussed. Class 3 is 30 to 40, and that is what we use in patients with varicose veins. A 45-year-old male with a case of varicose veins since last 4 years comes with the image shown below. Patient has a history of an ulcer 6 months back, which is healed 2 months back. So according to the CAP classification, what will be the classification for this patient? So always remember, when you see multiple findings, so you can see pigmentation, you can see the varicose veins, you can see a healed ulcer. Whenever there are multiple findings, we will always choose the highest possible value. So right, please remember that we always choose the highest possible value. So here the highest possible value is a healed ulcer, so it's going to be C5. It's going to be C5 is the correct answer. I told you, in case of multiple findings, always consider the higher value. This you should remember for your exam. EVLT and RFA are treatment modalities for varicose veins. Which one of the following statements is true regarding this technique? EVLT has a continuous pullback system and it is easier to master. False. RFA has continuous pullback system and is easier to master. False. RFA does not require continuous pullback, has smaller learning curve. This is true. RFA is meant for skilled vascular surgeons. This is false. RFA has a shorter learning curve. All of the following statements regarding venous ulcers are true except long-standing venous ulcers can develop into Marjolins ulcer. This is true. Ambulatory venous hypertension is the most acceptable theory. All varicose ulcers should be treated with antibiotics. No. Only infected ulcers should be treated. Otherwise, there is resistance if you give antibiotics prophylactically. So this is false. VAC dressings can be used. This is true. What is the amount of heat which is produced by EVLT? It is 60 joules per centimeter. This I've told you. 60 joules per centimeter is the correct answer. And that brings us to the end of this module on varicose veins. It is a very important module for the exam. Thank you.